My inspiration to work in diabetes came in two waves. The first wave was when I was posted as a medical officer in a rural district in Uganda after my basic medical training. So my first posting was in the Kiboga district, which is a rural, most predominantly rural district in mid-central Uganda. So while there, I was participating in care at primary healthcare level, first at the hospital, then at the health center 4. But quickly I realized that the healthcare system tended to focus more on infectious diseases, diseases that are more acute, like malaria, like pneumonia, like diarrhea. And then it was not difficult to realize that when it came to chronic care, service delivery was quite weak, right from all levels of care up to the hospital. The hospital seemed to be the level that had some level of structured services for diabetes and hypertension care. But as you went downwards, health center 4, health center 3, the services were quite poor. I remember when I was posted to the health center 4, I immediately realized that there were some diabetes patients, few diabetes patients, but there was no regular clinic. So they would come on any day of the week. The services were not structured. Sometimes the services were not readily available. And it is then that one of the initiatives that I undertook at that level was to establish a diabetes clinic, which we set on a standard day of the week, where we could provide a package of services. But even then, the level of expertise that we had, the level of knowledge about the disease was still relatively low, given the experience. And then the second wave came when several years later, because I worked in the district for 7 years. Then after my master's degree, I joined the School of Public Health as a lecturer, and that's when I went into research. And one of the areas around 2009, I discovered that there was quite a limitation in terms of the research regarding type 2 diabetes and indeed chronic diseases or lifestyle diseases in our context here. I noted that there were a lot of studies done in developed countries, in Scandinavia, in the United States, even in the Middle East. But there was a shortage of information regarding the burden of diabetes, both type 1 and type 2 in Uganda, and the whole range from just prevalence. It was not clear. The country by that time had not done a national prevalence survey, so we didn't know the burden of the problem here. We didn't know the readiness of the health system to handle type 2 diabetes. We didn't know what was happening, and indeed type 1. We were not sure of what was happening, especially at the primary care levels. When I looked at some of the literature, especially unpublished literature, it was mostly showing diabetes as a tertiary care disease. That is mainly at hospital level and with limited information about what is done at lower health facilities. So it's then that I gained interest in diabetes and also in lifestyle diseases. And around that time, an opportunity came for me to do a PhD. And immediately I, with the advice of my supervisors, decided to focus on lifestyle diseases and in particular type 2 diabetes.
That's amazing.
So
the work has now started officially, and we hope to be helpful in that particular arena, promoting research and information sharing, and it's because it's very, very important, I believe, in that particular path that you're taking.
Yes.